Well, great to see the board members here, but also a very warm welcome to all of the members of the general public that are joining us online this afternoon. Thank you very much for your attendance and interest. Just want to go through a few announcements before we get into welcomes and introductions. And you'll be aware that Staffordshire and Stoke-on-Trent Integrated Care Board meetings are meetings in public. They're not public meetings. Can I just ask colleagues if you'd go on mute, please? It'll just make a difference to the sound quality. As we get into the board, if I could ask if all cameras could be off except for the chair and those presenting, and when you come in to ask a question, please do put your camera on. As I've just said, if colleagues could keep their and members of the public could keep their microphones off, we'll get a better sound quality as we go through the afternoon. I'll invite questions from members of the public at the end of the meeting to cover any item that has been addressed on the agenda this afternoon, and questions submitted in advance of the meeting via email will be addressed at the beginning of the meeting in a moment. So just before we get into the apologies, I just want to note and place on record, firstly, my thanks to Peter Axon, our Chief Executive, and Paul Brown, our Chief Finance Officer, who are leaving the ICB during the summer. We'll obviously have ample opportunity to formally acknowledge Peter and Paul's significant contribution to the system in due course, but I just wanted to note that publicly today, our thanks, and we will do just that as you depart in the summer period. Just to say as well, we are working very closely at the moment with NHSE to coordinate a recruitment process, and that will be ongoing over the next month or so, and further reports will come back to the board. I also want to extend a very warm welcome to Mike Lawton. Mike, would you mind just popping your camera on for a moment? Mike is our new non-executive member of the board, and Mike joins us with an extensive career, following an extensive career in the commercial sector, most notably with Michelin, and he will be chairing our Strategic Commissioning and Transformation Committee going forward. So Mike, great to see you, great to have your skills available to the board, and a warm welcome from us all. Hope you enjoy your engagement with us going forward. We have apologies today from Paul Winter, and Tracy Revel is kindly covering. Phil Smith, Hayley Allison is kindly covering, and Baz Tamir from Health Watch and Anna Mather is representing Baz. And just finally, I have had a few notes that people may have to dip out and take calls of an urgent nature, to make sure that our response to day-to-day issues is being adequately maintained, which of course is critically important. So colleagues, please feel free to dip out if that should occur. We'll go, if we can, into item 7, the Leadership Compact. Once again, those who join the board on a regular basis will recognise that this is a very important document that we take at the start of all of our meetings across the integrated care system. We'll refer to it at the end of the meeting, but it guides the way that we wish to conduct our business. So a very important document that we guide our processes with. We'll move, if we can, now into conflicts of interest, and we have the register present. I just want to say that Mike Lawton, who I introduced a moment ago, has submitted his conflicts or potential conflicts, and Mike's entry will be on the March version of the register when it comes forward. Can I just pause for a moment and check if anyone has a conflict of interest on anything we're going to cover this afternoon? Okay, thank you very much, colleagues. If we can then move to enclosure 3, item 4, the minutes of the meeting held on the 16th of January, and we'll take those for accuracy first. So page 1, page 2, page 3, page 4, page 5, page 6, page 7, 8, 9, 10, 11, 12, and 13. Is everybody content with the content and accuracy of the minutes? I'll take silence as confirmation. Lisa, thank you very much for the production of those. We have at item 5, enclosure 4, the action log. There are 2 actions that we'll receive updates on today if we can. Paul Edmondson-Jones, can we have an update on the vaccination status, please, item 8?
Yeah. Hi, David. Hopefully you can see me and hear me. Hi. So the question was about the vaccination status. So the answer that I gave last time was that 100% of people who are admitted to the hospital with flu or suspected flu have their vaccination status recorded, and that's correct. Unfortunately, what we can't do is that is not then flagged anywhere on an IT system. So we can't routinely or easily just suddenly look and say, well, can we look back across everybody? So we've had 1,143 people admitted with flu over the last 14 weeks. At its peak, it was 114 people that were in Royal Stoke Hospital. There's a piece of work being done by a public health consultant within the hospital and the IPC lead for the hospital to do a manual audit of a selected set of notes to look at the vaccination status, etc. There's a paper that's going to the UH&M board in the next month or so, which is looking at how best the trust can react. To be honest, I think the conclusion is that the key thing is vaccination status of staff. I think the trust are going to be recommended. They look at a higher rate of vaccination for staff, looking at 75% of staff in direct contact and 55% of all trust staff. Of course, that has to be replicated in the community. So we need to look at GPs, we need to look at community staff, we need to look at health, social care staff as well. So that's really a summary of where we are. I can see Simon's got his hand up and wants to come in as well, David, if that's all right.
Yeah, absolutely. Paul, thank you very much for that. Simon?
Yeah, thank you, Paul. Thank you, David. Just by way of follow-up from all of that, I can confirm that we are taking, in terms of our winter planning for next year, taking special measures to identify patients who've yet been vaccinated and use that opportunity when they're in our care for whatever reason, whether it's inpatient or outpatient, but particularly outpatient, to use that opportunity to vaccinate them ahead of winter. That's already been through our processes, and we're doing it.
Thanks very much, Simon, for that clarification as well. And just check, Julie, you raised this as a point from the Chair and Chief Exec report. Just wanted to check that that gave you the assurance that you were seeking at the last meeting.
Yes, and thank you very much for that. So really, really good update. Thank you.
Great. Okay. Thank you. Heather, can we get an update, please, on the CHC reduction item 13 on the log?
We can indeed. Thank you, Chair, and apologies that I wasn't able to be at the January meeting. Otherwise, we may not have had an action for this. Hopefully, I'll be able to give you some assurance today. So I know that John raised a question in respect of people being turned away from CHC. Just to be absolutely clear, this is about us making sure we're much more tightly managing the process of eligibility for CHC. So people aren't being turned away, but if they don't meet eligibility or they're no longer eligible, then they are being notified of that. Just to provide extra assurance, to date, we've had nobody who's been stepped down from CHC who's then been subsequently readmitted onto full continuing healthcare, I should say, in full. And just to give perhaps an extra line or level of assurance, if an individual is no longer eligible as a result of that process, but they reside in a nursing-only environment, then we do use the funded nursing care status. So that's provided, even if there is no apparent funding nursing care need, to stop people from being unnecessarily moved to a different location that's not in their best interest. Really important to underline all of that with the fact that, as Paul highlighted last month, all of those decisions are made jointly with local authority colleagues in agreement. And we absolutely put patient safety at the top of the list when we're making decisions related to all aspects of this. So hopefully that covers that one off, Chair.
Heather, thank you very much. John, and I think you're on the call. I just want to come back to you and just check that that covers off the point that you raised at the last meeting.
So I'm grateful to Heather, and has a substantial answer. I think it does. I would be wrong to say that we in the County Council aren't concerned, because we are. Last month alone, we had over £300,000 of additional cost from step down from CHC to social care. And if you cast that across an entire year, the impact in terms of our financial position and the county's financial position is going to be significant. Now, clearly, if it is right and legitimate that they should be receiving social care rather than continuing healthcare, then so be it. But we should be under no illusions that this is a transfer of financial pressure from one part of the public service to another. It doesn't go away completely.
Okay, thank you, John. Patrick?
Just for completeness and absolute clarity, I completely support everything that John has just said there. Thank you.
Okay, thanks, Pat. So with that said, Heather, I guess the important point here is the ongoing dialogue around all of these processes. And I'm sure John and Pat would agree that the more we can get people together to make sure that we understand what one opportunity or one process delivers something in one place, how that may impact on another. I'm pretty sure that will be picked up through executive or chief executive groups.
Yeah, thank you, Chair. And in addition, of course, I'm always happy to have a conversation with either or both. And I know that there is numerous forums where dialogue is taking place. So if we need to pick this up as a particular emerging issue, then I'm happy to have further conversations with colleagues across the system.
Yeah, great. And John, I'll bring you in now, but I guess John, Pat, Peter and chief execs, again, an important item to make sure is picked up on the weekly chief exec call. John?
Yeah, so I've got to come back on that because it at least implied that we as chief executives hadn't previously raised this issue. In fact, Pat and I have written twice to Peter on this issue, and we're about to write a third time.
Okay, thank you, John. Okay, so we'll move on, if we can, into questions submitted by members of the public in advance of the meeting. Tracy, I think we have received one question.
We have, Chair, from Syed Abrar, and I hope I've pronounced your name correctly because I believe you are on the call. And the question is, as the adoption of artificial intelligence continues to shape the delivery of mental health care, what is the ICB's approach to leveraging these tools to enhance outcomes, improve efficiency and ensure equitable access to services? Additionally, if you're a third party that is able to support the ICB's strategy and priorities, who would be the best person to contact regarding this matter in the first instance?
Thanks, Tracy. Chris, are you able to take that question?
Yeah, sure, David. And Syed, thank you very much for this question, because it's very important for the ICB, because we see artificial intelligence really as a key element in digital transformation to help our clinicians in applying best practice, to eliminate unwarranted variation across the pathway of care, and to support our patients in managing their health and their conditions. So to that end, Syed, we in February last year, so it's a year ago, our governance body around digital, that's called the Digital Collaboration Forum, we approved the addition of artificial intelligence into our ICB digital or ICS digital roadmap. And that's to develop the use of AI to support our staff in decision-making, in diagnostics, and completing other complex tasks. So we have a number of projects that are underway, which I'll touch on in a moment. So across the ICS, the providers are using AI in some diagnostic areas, for example, breast screening and stroke care are some examples, and also in translation services. As with other digital healthcare technologies, we need to be very careful here as well that we have the right artificial intelligence policies and procedures and strategy in place. And I'm pleased to say that we have a AI strategy, and we're also working on our policies and standard operating procedures around this. In community and mental health, in particular Midlands Partnership University Foundation Trust, they're adopting virtual assistants for 24/7 chatbot, appointment viewing and cancellation, and referral screening tools for talking therapies in Shropshire, Telford and Wrekin, and adult mental health. MPFT also adopt robotic process automation. I accept robotic process automation is not AI specifically, but we do use that technology for processing en masse repeatable administrative tasks. We've been doing a lot of work around recruitment and harmonization of recruitment processes, but also around clinical systems management, things like death registration, spine tracing, and data migration. And they're also doing work around administrative improvements. So talking about taking minutes and recording actions using Copilot. North Staffordshire Combined Healthcare also using this for administrative support around Copilot as well. So I think, just in closing, this is a really exciting area. It's a growing area. There's a lot of hype and interest in it. So your final question was, who can you contact? Please do contact me or Sally Deacon, who's the head of digital transformation, and be very happy to have further conversation.
Okay, thank you very much, Chris, for the response. Alison, I know you've got your hand up now. Would you mind waiting to the end of the meeting to raise any confirmation on this particular point?
I'm quite happy to. It was just a nice sort of welcoming the fact that they're looking at policies and to offer my help and support from my previous role in working with the AI Digital Regulation Service. So that's all it was.
No, that's absolutely great. And thank you very much. And please do come in at the end when we bring people in for questions. Thank you. Okay, thank you very much, Chris. We'll move, if we can, into item 7, the ICB Chair and Chief Executive report. I'm just going to refer to one item and then hand over to Peter. One of the great things about the chair role is that I get the opportunity of getting out into the patch and actually meeting people. And I've been out to MPFT and UHNM, and this month I was fortunate to be invited over to North Staff's Combined Healthcare by the Chief Executive there, Bucky Adiemo, and her team, and visited there on the 5th of February and had a walk around the Harplands facility. And I just refer to my notes. It was great to actually meet the people who were working in the all-age crisis walk-in and crisis care access team. Fantastic facility, taking a lot of referrals and dealing with a lot of inquiries from people in the community. Really great to see that and the energy in there. And then to go down to Ward 2 and actually meet the team as part of Project Chrysalis. And it was great to meet people like Sarah Lavin, who's a young deputy ward manager on there. And it was really inspirational to see somebody like Sarah, who's obviously a great leader of the future and doing a great job to provide a super atmosphere in quite challenging circumstances. So Bucky and the team, many thanks for inviting me there. It was a great day. And the week after, we obviously had the opportunity of participating in your strategy discussion at Port Vale, which again was really, really great to be at. So with that said, Peter, can I hand over to you to bring forward any escalations you want to from the report?
Yeah, thank you, David, and good afternoon, everybody. I'll be brief because I think, well, what I want to mention actually is the bulk of the session itself, actually. So I was just going to head it, if that's okay, which is around planning. So as is tradition at this time of year, Q4, as we head into the 1st of April and the new financial year, we're doing a heck of a lot of work around planning for next year. The timelines are quite challenging, I think it's fair to say. Of course, we always know that the 1st of April comes around each year, but information and final agreements on allocations, etc., have taken a little longer than I think all anticipated. So we are dealing with some relatively concertinaed timelines in that regard. I think it's fair to say that the envelope that we have been allocated, and I would argue all systems actually across the country have been allocated, are also very challenging. So we both have the timeline difficulty, but also how we will resolve those challenges. We're working really hard as a collective. One of the things that we've focused on over the last 3 years as an ICB and a wider group of leadership in the system is that effective working together. So I'm really pleased that we are doing that, working very well together as a group, a constructive group. But of course, the scale of the ask itself does mean that, irrespective of how well you work together, it is a tough ask. The 3 areas that we're working on are the first area being if you like, the more traditional stuff around cost improvement programs, efficiency and productivity within individual organisations, including the ICB, of course, who lead on a number of things, including CHC, continuing healthcare, as mentioned a moment ago. The allocative efficiency opportunity across the system, that essentially is about moving resources into different areas, different environments, benefiting in part, of course, from the productivity opportunities that each organisation is looking to achieve and deliver, to ensure that we work in a different way, more proactive and preventative way, to reduce the burden on reactive services across the system. And then finally, the programme of work that we're describing as tough choices, which essentially will ensure that we do submit plans that will be balanced. Of course, that the ratio of values between those 3 areas to be able to close the gap, we don't yet have that detail, so we can't report that here. We'll have more information in March, we would expect. So that's obviously close to the 1st of April. But work is, I suppose, the point being of all of that, it's to assure people that work is going on. We are working very hard to ensure that we can deliver the best possible plan within the resources that have been allocated to us. And that is clearly the expectation from the centre. What can we achieve within the resources that have been allocated to us? I won't give any more away, David, because I suspect there will be more detail and conversation as we go through the meeting in that regard. But that was the one thing I wanted to mention for now. So I'll stop there, David.
Okay, and thank you, Peter. And Peter, one thing that I didn't share with everybody on the call is that you're having technical difficulties with your camera this afternoon. So it's not that you're being shy; you literally cannot get onto the screen. So we'll note that. So just pause there if there's any points on any other aspect of the Chair Chief Exec report that colleagues want to raise. Julie.
Thanks very much, and thanks, Peter. Couple of points from me. One around the Community Transformation Programme and the importance of that programme. I just want some assurance around the pace and the governance arrangements around that, which is critical to actually achieving change, but also the requirement within the guidance to shift to the left. So assurance about pace and governance arrangements. And the other one, I just wanted to, you sort of touched upon it, Peter, but just thinking back to John and Pat's earlier point around continuing healthcare, is as part of the planning process and each organisation working through its own efficiencies, I just want to make sure that I know you say we're working together, but from a process point of view, is understanding when we take through those efficiencies what the QEIA process is, so that we fully understand the implications for other providers within the NHS, but in the wider system as well.
Julie, thanks for the question. Good to see you've cured your camera, Peter. So over to you.
Well, I've temporarily, it's gone off again whilst Julie was talking. I've got it back, hopefully. So, so in terms of the community transformation piece, we actually have just come off a call with NHS England where we've discussed a lot of this in, as you can imagine, quite a lot of detail. And Elizabeth may want to come in a second on that, and actually Paul Edmondson-Jones on the wider piece around QIA, EQIA, and linkages with the clinical body on the particularly the tough choices stuff. So look, I know this is a bit of a cliche, but we are on a journey in terms of the community transformation programme. We know the areas of opportunity. We're developing 8 key themes, 8 key topics within community transformation. A number of workshops have taken place to build those themes. Critical, of course, within this is that everyone goes on the journey together. We all move forward together. So there's joint agreement that, for example, those 8 key themes are the right themes for success over coming years. And within that, we're using data and evidence. So we know that we admit more over 75s, particularly in terms of the frailty agenda within our UEC portals than most, not all, but most systems. So the data indicates there's a clear opportunity to be more proactive, more supportive in that space to prevent those admissions in the first place, which in turn, of course, creates the momentum around continuing healthcare and all the other services that kick in at the point of discharge. So that it's data driven. We're ensuring that we take colleagues on throughout right on board with this, and we are building the programme as quickly as we possibly can. But the reality is much of this is transformational. It's not small incremental improvement that requires the odd policy change here and process change there. This is big ticket stuff and therefore will require time to implement. And that in part was the conversation with NHS England a moment ago, that the reality that is this will take time to deliver. Just on the checks and balances piece, one of the key things that we're doing is ensuring that there's regular interface between the various leads who are delivering the programmes of work, as I say, described at a high level, the 3 key areas, to primarily ensure that there isn't overlap or there aren't gaps between the various programmes. The last thing we'd want is to, at this point in time, when of course resource is scarce and vital, is to have people duplicating effort across the system. That includes local authorities wherever possible and necessary, and other system colleagues, so primary care is linked into that as well. So we are making sure, however best we can do it, that duplication, assurance processes, etc., are in a good place, but it is all moving very fast. So I don't know whether either Elizabeth or Paul on the tough choices stuff might want to come in at this point, but yeah, it is, you know, I've got to admit it is a challenging time for us given the concertina timeline that we've got, Julie.
Yeah, thanks, Peter.
David,
Julie, do you want to come back in?
Yeah, just very quickly. Sorry, Josie, if that's all right. Thanks, Peter. And as you know, I'm a chair of a community trust elsewhere, and it does take time, I think, you know, and it has taken time over in where I'm a chair as well in that system. I suppose for me, my one question was, but there is a lot of systems that have made good progress. So how are we talking to other systems to learn from them in order to increase the pace that we could perhaps put into Staffordshire and Stoke-on-Trent?
Thanks, Julie.
And again, it might be something that Elizabeth would want to come in on, but I'm aware that Lincolnshire recently, just as an example, where that Lincolnshire recently presented at one of our workshops that all the work that they've been doing over there. It's a fair point. It is important that we don't try and reinvent the wheel. Obviously, the subtlety of how we implement already achieved programmes elsewhere within Staffordshire is something that we need to consider. But the basic blueprint, absolutely. Let's pinch with pride, I think might be the phrase.
Okay. Elizabeth, do you want to just add to what Peter's said in response to Julie?
Yes, please, David, if that's all right. So I'll try and be reasonably brief. So I think there's just 3 things I'd probably highlight. So absolutely agree with Peter's point. So we are asking systems to come and share their experience with us. So the example that Peter gave there around Lincolnshire, so they joined our system-wide workshop and presented about how they did this work. So we learned a lot from how we might want to approach the work. The other couple of things I wanted to say, though, I think is that this isn't work from a standing start. So there's lots of work that we already have been doing as a system. The opportunity here, though, is to connect it all up in a slightly different way. really understand, and this is my third point, how perhaps jointly with our local authorities as commissioning partners, we can start to be more coherent about our strategy to, for example, promoting independence, which is obviously linked to this idea of community transformation. So I don't want the board to feel like this is a new thing for us. The thing that's new is our system-wide focus on it, and this sense that we're going to agree these 8 areas to be able to work on. We're going to quantify the impact of those. We're going to build that into our plans, and we're going to monitor it. And that's a different approach. So that's new. But with lots of the content, we're either based on work that we have already got going as a system that we fit. So we haven't got this idea of a standing start, and we are asking other systems to help us with the evidence base, particularly on the impact. So, for example, there's been some really good work gone on around care homes in other systems about how the population in care homes can be supported in a different way. So we don't have to go and reinvent the evidence of the impact of what we're going to do. We're going to be able to use their evidence to help inform our plans. So we're very much trying to learn from other systems, both on what they did, how they do it, but also how they measure the impact of that in terms of that left shift agenda and the broader plans. So hopefully that helps fill in some of those gaps for you, Julie. Thanks.
Thanks.
Thanks, Elizabeth. Thanks, Julie, for the question. Josie?
Thanks, David, and thanks, Julie, for raising that. I was going to ask about the community transformation, but we've done that. But the other thing I did want to mention, because I do sometimes think we forget to mention the really good things that are going on. And in your report, David, yours and Peter's report, the section under primary care about the IT equipment donation and the apprenticeships is fantastic. Particularly the IT equipment donation in the broader remit we've got as an ICB. I think that sort of work is really excellent. So I just wanted to make sure we didn't gloss over some of those things that are really good, and the apprenticeships in primary care, another excellent piece of work as well. So thanks for feeding back on those.
Yeah, Josie, thanks very much for noting that. John?
Thank you. Really good discussion this. I think 2 points I would make. The first is it's absolutely right that we look at the tough choices, and we must do that collectively. That's just good stewardship, good governance. But what we must avoid is contradicting ourselves. So, sort of accidentally on the one hand, sort of abolishing, key programs which are actually critical to the community transformation process. So it's very important that we're coherent in terms of our overall approach as we make those choices about which of those tough choices we take. So that's the first point. The second about what unlocks transformation. Well, probably for the only time in an ICB board meeting, I'd like to quote Elsa from Frozen, which is let it go. So one of the things I really feel that we as an ICB have got to do is empower those who are closer to the front line to make the necessary changes. We've got to, put absolute backing behind the provider collaborative. We've got to put backing behind place-based working and empower those frontline leaders to actually make the changes that will ultimately improve performance and outcomes, as well as saving us the money we need to save.
John, thank you for that. And those are points I'm sure resonate with the whole board, and well made. So thank you for that. Thanks for the discussion. As John said, it's been a rich discussion on the Chair and Chief Exec report. Thank you for that. We note the points that have been raised, and we've received the report for assurance, and be assured that the leadership are working on each topic. So if we could now move into item 8, another important agenda item for this afternoon, planning and allocations at enclosure 6. Paul Brown, can I hand over to you, please?
Yeah, thanks, David. I think some of the points have been covered already in that early conversation, but I'll quickly go through kind of where we are to cover briefly the timetable so that the board are cited on that, the process that we're going through as a system, the key priorities that we're trying to address, and then some of the money position that we're trying to manage. So as Peter said, the timetable is quite condensed. So we have now got the planning advice and the allocations. We received that during January, so that's probably at least a month later than we would usually get it. And the endpoint is defined as 27th of March. So whereas last year, the board will remember we ended up with a very protracted planning process. I think we do very much welcome a shorter planning process. To be honest, we need to get the plan done and agreed, and there's nothing like a deadline to focus minds. The sooner we have the plan in place, the more time we have to implement it, frankly. So although it is, I have to say, extremely hard work right now for all of the teams, all the system, on balance, I think we do welcome that clear end point on 27th of March. You'll have seen in the paper that there will then be a board-to-board conversation. So this board will be meeting with national board to go through our plans. So that's the timetable. The process, as Peter said, and I agree with him, we are working really, really well as a system. And certainly I've now been here 5 years, and each of those years, I would say we've made a step change in the way we work together and collaborate together, and that's continued, I'm pleased to say. And although the situation is very, very difficult, we are very much working together, supporting each other in ways that we perhaps didn't when I started. So that's good to note. We have a lot going on. Elizabeth and her colleagues at the providers, the directors of strategy, are taking a lead role in ensuring that plans are going to be triangulated within organisations, but they also need to be triangulated across the system. So that group is helping to do that. We then are feeding into various groups. So I'm certainly meeting with my CFO colleagues at least weekly, often daily, to be honest. I know Mish is doing the same with the CPOs, Paul with his CMO colleagues, and Peter with the chief executives. And in fact, on a Monday every week now, we've got a combined chief executive and CFO conversation. So because of the pace we're working at, it's important that we have that ability, and that means that we are able to turn things around pretty quickly. So all the meetings are in place, the process is in place. It's now just sort of head down to get it done. The priorities, there's a slide I'll perhaps just draw the board's attention to in the pack 34 of 96, which hopefully quite neatly summarises what we've been asked to do. I think there is a lot of clarity from the centre this year, which is really helpful in terms of what are the priorities. And as you can see, the priorities are reducing waiting time for elective surgery. And we've got specific targets there around the numbers to be waiting less than 65 weeks and 52 weeks. Targets around improving urgent care and times for ambulance responses, which again we totally support. Thirdly, the focus on primary care and general practice, and particularly a focus on urgent dental care, which is an area though where we know we need to do better. And lastly, your continued focused on mental health and learning disabilities. So those encapsulate what our plan is centred around. Very, very clear messages. Again, Peter alluded to this, a very clear message from the centre that we have to live within the money. And that has been articulated to us in many ways, including directly from Secretary of State. So that is the brief. We have a budget. We have to live within it. Clearly an expectation that the work on efficiency continues. The focus on productivity. So this is not so much, not just a Staffordshire thing, a national issue, is that the NHS as a whole has seen growth in workforce, but not a corresponding growth in activity. So capitalising on the higher levels of workforce that we now have in place than we did certainly pre-COVID to treat more patients without increasing the workforce. And we think, unfortunately, there'll have to be some reductions to the workforce, that way driving higher levels of productivity, and really to maximise that. And we give some very helpful work done by the centre that benchmarks our position relative to other organisations, and we're using that as a central part of what we need to do in terms of ensuring that no stone is left unturned in terms of the pursuit of the most efficient and productive delivery of healthcare that we could possibly do. All that alongside maintaining and ensuring safety in all that we do, and a focus on quality, as well as continuing the good work we've done in terms of addressing inequalities and shifting towards prevention, and finally the third part of the area signalled by Lord Darcy, making the shift from analogue to digital. So that comes together into what we think is a very sensible set of priorities and focus. The challenge, though, is very, very significant. The board know that we had a difficult financial year. I'll come to it later, David, on the agenda item. We've actually had a pretty strong second half financially, but the money situation is extremely difficult. The NHS has been fortunate that wage awards have been agreed. So the strike action that we saw a while back that was incredibly disruptive to all that we're trying to do, thankfully that has been resolved, and wages have been uplifted for key staff quite rightly. And I'm pleased to say that the allocations do fully recognise that, and so the funding for the NHS to cover inflation is included. Beyond that, though, there is no growth, and there are expectations for efficiency improvement. So when you layer that on top of the last few years during the COVID period, we as an NHS were relatively generously funded, and we were able to live within our means. And in fact, we were able to strengthen balance sheets, and we made a significant voluntary contribution to the local authorities for the Better Care Fund, for example. We were able to do that, which I think gave some financial stability to the system for a while. And bit by bit, that balance sheet strength has been spent. So we have now got to the point where we no longer have that to call upon, and that has driven what we call an underlying deficit. So we have managed to live with it in our targets almost, not quite, but almost, but only by utilising those resources that we'd accumulated, and they are now run out. So we're going to a period then with starting with an accumulated challenge at a period when there is no growth, there is an expectation of efficiency, and of course we're seeing with patient demands, they continue to increase across primary, community, mental health and acute care. So David, it is a challenging situation for us and for all of our partners. As that previous conversation indicated, what we're trying to do is ensure that we maximise what we can do through efficiency and productivity, and that will kind of narrow the ask, but I don't think will eliminate the ask. So we'll be left with further that we have to do, and really what we're seeing is kind of two big areas for that. One is the community transformation work that Elizabeth referred to, and then the second is going to be some of the tougher choices where we might well have to say we cannot afford to provide all of the services that we would like, and through that we are intending to do what we've been asked to do, which is to come back to the board in March with a balanced financial plan, delivering the targets that we've been set. Hopefully, David, that sets the scene for perhaps a conversation. You might feel we've already had it through the earlier part, but hopefully that explains where we're at.
Paul, thank you very much for taking us through that process, and clearly a lot of work going on behind the scenes. There's a lot of meetings, as you described, to gear this up ready for submission. And I know in terms of conversations that Peter and I have been having with chairs and other key leaders across the patch, socialising this widely, and that'll culminate in discussions before we go to the national board to board that you described. So just pause there and invite any reflections or questions on what Paul has presented to the board this afternoon. Okay, Paul, it looks as though you may have covered that off very clearly. Megan, welcome.
Thank you. Thanks, Paul. You set that out very clearly. I suppose I just wanted to make a comment really about the overview of priorities set out, and the second batch of four, which are not priorities, but they're things that we must do to achieve the goals. And the first one is around living within the budget allocated, reducing waste and improving productivity. And then the last one along there is making the shift from analog to digital. And there was just something for me around the link between improving productivity and making the shift from analog to digital. And we know that capital investment is absolutely key in making that shift from analog to digital. And that is key to improving our productivity. And what we also know that is, as a system which didn't achieve break even this year, we were penalised in terms of our capital allocation. If we don't achieve break even this year, we'll also be penalised next year as well, which just makes that shift manual to digital even more difficult. So it was just a comment really on the challenges. Systems that are particularly challenged then can get further penalised in relation to their capital investment in particular, and how difficult that then makes it to do some of those things that we actually all really want to do around improving productivity and shifting analog to digital. Thank you.
Thanks, Megan. Paul, do you want to come back on that?
Completely agree, Megan. I mean, we do need that capital investment, as you say, to do some of this stuff, and we're certainly lobbying hard for that. And I think some of the community transformation work as well would be an element of double running with that before we can deliver the results. And it goes back to Peter's point about timing and timescale. That, you know, it is difficult. In the ideal world, we'd have been given time and investment, and that would make what is a difficult thing perhaps a bit more straightforward. But we don't have that, so we're going to have to manage with constrained capital. And you're right to point that out. And we're also going to have to live with an expectation from the centre that we can bring about the transformation extremely quickly, and that's what we need to do to live within our means. But clearly, that is no easy feat.
Okay, thanks, Paul. Elizabeth.
Thank you, David. So I just I kind of support Megan's kind of comment in terms of the link, but I just wonder if there's also something for us to consider though around alternatives to kind of conventional capital to do some of the kind of digital innovation we might want to look at. So I'm just reflecting on a conversation I had earlier this morning about, digital, and organisations that we might want to approach to partner with, to be innovative around helping them develop the relevant kinds of technology and the proof of concept that they might be looking for. So there are ways perhaps, we could think about kind of innovation via other networks, etc. So I agree there's maybe a constraint there, but there's probably some other alternatives that we could start to explore to see what we could do despite, in essence, that constraint you're describing. So I just wanted to say I think there's things that we probably could do perhaps and could start to explore, and we need to kind of be innovative about our thinking on how might we do some of that as well. Thank you, Chair.
Yeah, thanks, Elizabeth. Really welcome point. And Megan, judging by the nods there, you were in agreement with Elizabeth's point there. Yeah, thank you. Okay, so just check any further clarification or questions on this paper. If not, we're being asked to acknowledge the release of the 25-26 National Planning Guidance, Provider Efficiency and Productivity Packs and Financial Planning Guidance and Allocations, acknowledge the local milestones, and acknowledge the need for the board to submit assurance statements on the 25th of March as part of the full submission to NHSE, and the timescale for that has been laid out by Paul this afternoon. So if everybody's happy to receive that, Paul, thank you for presenting the report. Moving to item 9, if we can, and closure 7. Heather, we've got the quality and safety report.
Thank you, Chair. Usual format of the report, just a couple of things I want to draw out again, as I always do. So the first, we've started with this report with a reference to the continued pressures around urgent and emergency care, and hopefully provided some assurance in respect of the actions that were undertaken in partnership with all system partners, but particularly on this occasion working with UH&M in respect of harm reviews at ED, so patients waiting in ambulances, waiting to be seen, undertaking those harm reviews in partnership. We've undertaken some high impact team visits. We've introduced that, and I know we've referred to that in the report, so everybody will have read it. But again, looking at what can be done to improve flow and hopefully then have an improvement impact on the UEC pathway. And of course, we're also doing our normal visits. So although we've extended them to focus more on urgent care this time, so there's reference to that in the report as well. So just really to underline the activity around the urgent care pathway. Secondly, and I'm bouncing around the report a little bit, so apologies if you're trying to follow me, please don't, because I'm picking them out in order of significance, I guess. Last time when I wasn't at the board, so I apologise for that. There was reference to Darwin in the questions, and I know that Bucky answered that, and it's Bucky's service, so Bucky will know much more about it than I do. But just wanted to make direct reference to the fact that this did come up in the last board meeting, to remind everybody around the table that, and of course our members of the public, that this is a service that's commissioned by NHS England. But we work very, very closely with NHS England and with all of our providers in this kind of service. There is increased oversight following a visit by NHS England, and a comprehensive improvement plan is in place. So as I said before, we'll continue to work with Bucky and her team and with NHS England to make sure that that service is sustained. I think most importantly, that it's really, really important to note that there is no impact on admissions. So people aren't being stopped from being admitted into the unit. It's just about driving some improvement. Thirdly, I wanted to talk about the improvement journey that we've already talked about today in relation to all age continuing healthcare. So that journey is continuing. We've significantly reduced the backlog of reviews and established much stronger systems and processes so that we're doing everything we can to prevent an accumulation of further backlogs in the future, which will be a big achievement if we manage to maintain it. And I am confident, based on progress to date, that we will. And the focus, as I said before, of this, whilst it's having an impact on finances, and we've talked about that earlier in the actions, the primary focus is about making sure we're making proper best use of the continuing healthcare framework and that people are getting safe, high quality care. And then just to pick up a couple of positives, and there's quite a few positives included in the report, and we do try and keep it fairly balanced. There's a couple of things that I wanted specifically to draw out. One is the continued progress and development of the continuous quality improvement network, which is very ably led jointly by John Costello from Midlands Partnership and Lee George from my team. That is going from strength to strength and works across both Staffordshire and Shropshire. And I don't think it's possible to overstate the impact that that's having. And of course, that will bring with it some significant improvement activity and improvement projects, which will closely link to the work we're talking about in terms of community transformation. So it's all really, really key, but a real success for our area. Secondly, on that positives list, I wanted to talk about the sustained improvement in LEADER, the learning from lives and deaths of people with learning disabilities. Not something that we ever thought we'd achieve. Well, I think we were always optimistic we'd get there, but I think because we had such issues in the past, we were concerned we might not. We are in the place now where there is only one overdue review, and that's overdue for a good reason, not because of a delay in the system. And as I said before, we continue to work to maintain that. And then I just wanted to draw everybody's attention, if you've not had a chance to read the paper in full detail, to the what we really, really welcome, and we've talked about at length in the system quality group, the development of the Social Care Academy, which has been no mean feat for our local authority partners, and which will bring a real opportunity and opportunities for our population, but also help to enable us to grow our own workforce from a care home point of view. So very quick counter through, lots of points in there, and I'm happy to take any questions.
Heather, thank you for that, and thank you for the report. And just echo the point you've just made about the Social Care Academy. I wanted to pick out the LEADER issue as well. I thought that is a real achievement from where the system has been historically, so that's really welcome. And just under 6, I thought it was important to note as well the movement around the CQC inspections as well, noting the county hospital move from requires improvement to good, and also Brewood Medical Practice and Millrise Medical Practice also receiving good following their inspections. So it was good to see that in the report as well. Julie?
Thanks, David. Thanks, Heather. Really good update, as always. You mentioned about the alignment of continuous quality. I was going to ask about that, continuous quality improvement, but I just wanted to pick up about the discharge work that's mentioned in here, which again, for me, is an integral part of community transformation. So I just wondered if you could just give a bit more update and assurance around that alignment.
Sorry, I couldn't get my mouse to go to my mute button. Yeah, so in terms of the alignment of the continuous and quality improvement work, is that what you're asking me for, Julie?
The discharge work.
Okay, yeah, sorry. Let me just pick up where we are with that. Just bear with me a second.
I think Elizabeth's going to come in as well.
Oh, Elizabeth might want to come in first while I find my place in my report. Got everything ready in my head except what you want.
Okay, you find your place, Heather.
Thank
Elizabeth.
you, Chair.
Is that all right, Heather?
Yeah, no, that's
I think I can probably help.
You.
I think I can help with Julie's question. Julie, can I just double check? I think your question is about how are we, so Heather's reporting some challenges with urgent and emergency care, discharge focus in the quality safety report. How are we going to address that in community transformation? Okay, yeah. Cool. I can see you're nodding. Brilliant.
Oh, okay.
So, Heather, do you mind is it all right if I give just a bit of a response, and then if there's anything to add? So, I absolutely. So before I think Peter actually mentioned, and I think I mentioned it too, we're getting really clear on what are the areas we're going to focus on next year. So whilst our community transformation programme is the umbrella for our significant change, the work from across our portfolio areas, including urgent and emergency care, will be really critical. One of the areas we've definitely identified is a focus on discharge, and that's really around what we do through the integrated discharge hub arrangements and what happens around that discharge to assess model. And we've also, that's also been an area of priority focus that we've been having in discussion with our local authorities commissioning partners, as I mentioned at the beginning too. So just to provide an assurance that what we're learning kind of operationally and around the quality and safety agenda around the current circumstances of our UEC performance, we're absolutely feeding that into the transformation opportunity that will come about as part of community transformation. So one of the, it's probably no surprise, one of the 8 areas of priority is going to be that focus on those integrated discharge hub arrangements and the component parts of services that need to sit around coordinating that discharge programme and helping to improve flow. So hopefully, Julie, that addresses your question.
It was just to hear that assurance that it's all joined up and not being separated. Yeah,
absolutely.
Heather, thanks, Elizabeth. I'll just come back to you, Heather, in case there's anything you wanted to add.
No, not specifically. I think Elizabeth's done it complete justice there. I think I was looking in the wrong section of my own report, and I'd referred to the high impact team action and the impact around discharge there, and obviously the impact on flow. So I'd probably be repeating myself if I went back over it. But thank you.
Yeah, that's great. Thanks, Heather. Bucky.
Thank you, Chair. As Heather mentioned, Darwin, I thought it might be helpful just to perhaps reiterate what I said last time. And again, it remains that it is, I suppose, a difference of how we might categorise escalation processes. And I'm pleased to report that there has been a further meeting as well as on an hour's visit to Darwin, and again it remains that there are no concerns with regards to what was identified as an issue before.
Yeah, Bucky, thanks ever so much for that. That's really helpful clarification to the board this afternoon. Megan.
Thank you. Thanks, Heather. I just wanted to pick up the point that you mentioned, David, around the leader programme, and it's really welcome news, Heather, that we are making considerable progress and reducing the backlog of reviews. I just wanted to ask whether are we making progress in relation to the outcomes for people with a learning disability and autistic people? It's great that we're making progress around the reviews. Are we making progress around the outcomes that they're experiencing as well?
Yeah, thanks, and I think without wanting to throw Elizabeth under a bus, she may want to come in on this one as well, because this comes under Elizabeth's domain. And certainly where we've identified that, obviously from a leader point of view, when we do the leader reviews, the learning from leader will be translated into practice. So when we're developing services around people with learning disabilities, autism, then we need to know what has been picked up as part of those leader reviews in order to make those services better going forward. And that's where that matrix working across all directorates is absolutely key to the success or indeed the failure if we don't do it properly of what we're establishing across the system. And of course, that will all feed into the community transformation work going forward. But I might just pause there and see if Elizabeth did want to add to that as well.
Thanks, Heather. Elizabeth?
Thank you, Dave. Thank you, Heather. Yeah, so specifically to add to the points that Heather's raised, in the plans for 25-26 that are linked to the mental health, learning disability and autism portfolio, there are some specific actions in there that are planned around improving outcome around areas where we know we're challenged. So, you know, as a couple of examples I can think of straight away without having the kind of plan in front of me is there's some things around kind of ongoing focus on health checks, but not just the delivery of the check itself, the linking individuals into services that they then require as a result of those health checks, because ensuring they get appropriate access to all the other to universal health services in the same way as everybody else. It makes a contribution to the kind of particular point in Heather's point around the leader reviews, and also one of the other areas is around some of our really individuals with long-standing and complex needs where we've got comprehensive packages of care for those individuals, and really reviewing about the nature of those packages of care in terms of, are they enabling people to live their best lives? Are we ensuring that those placements offer people the opportunity to gain life skills and not just kind of provide a sort of sense of treatment and safety in the moment? So that focus on re-ablement. So they're on enablement, apologies, for kind of like broader, on broader life skills. So there are a couple of examples. So there are some very specific examples of pieces of work that are in the plans for that portfolio area for next year.
Thanks, Elizabeth. Megan, okay?
Yeah, I suppose it's just I'm specifically interested in outcomes. Are we having a difference? Are we making a difference in the outcomes in reducing the inequalities and the health inequalities that people with learning disability and autism have? So it's great. It's fantastic to hear about all the work which is going on to make changes to performance measures around inputs and outputs, I suppose. But it's just that that real difference in terms of outcomes that I suppose I want to make sure we retain a focus on. Thank you.
Yeah, and Megan, just on that, if I can, I know that the board is going to do much more exploration around the Oliver McGowan training. And I know from speaking to Karen in that regard, who will lead that really gets into engagement with service users to have the discussion around, what Elizabeth was describing there, actually, that, this is about me living my best life and getting the best opportunity from it. So there's quite a bit of work that we want to do with the board and will do with the board. We've done the taster of the Oliver McGowan stuff, but it goes much deeper into, I think, where you're taking this conversation to at the moment. The sooner we can get into that, the better, really. So, Heather, if we could just keep that on the radar. I know we've got it planned that there will be a specific session, not only for the board, but also the chairs from the system have also asked as well for a deep dive into that particular area as well. This is an incredibly important area of work. Okay, thank you, Megan, for raising that. Heather, thank you for the report. Just check there's no further questions or reflections on that. If not, we've been asked to receive the report, seek clarification and further action as appropriate, be assured in relation to the key quality assurance and patient safety activity undertaken in respect of matters relevant to all parts of the integrated care system. So thank you for that. We'll move straight into item 10 if we can, the finance and performance report. Paul, I'll hand over to you, and I assume Hayley's going to do a double act with you on this.
Yeah, yes, please, David. So I'll pick up the money stuff first. Hand to Hayley on performance issues, and other colleagues, obviously, if there are other performance issues you want to cover this afternoon. So the I&I regime, as it's called, is well underway. So we were placed into that regime. The board will recall that at month 4, we had the crystallisation of a number of risks. The key one, which I'll return to in a second, was around out of system provider contracts where we were, through a binding conciliation process, asked to pay out about £30 million, and that added to other pressures that we had, and we were signalling a potential miss of the plan of about 100 million a month before. The INI regime has been underway for a while now. Has 5 parts to it, and I think all are working to a lesser or greater extent. I mean, one is around enhanced controls, and we put in place delegated limits around spending and quite a bit around workforce. And I will perhaps, Mish, if that's okay, just ask you to say a bit about workforce, because it's whilst the process has been good, I think we've got a good process of grip and control. We do have some workforce concerns in terms of the numbers that we need to probably alert the board to. Second was around the CHC work that has been discussed already in this meeting, so I won't labour that, but I agree with Heather about the improvements, and I absolutely agree with her around the focus on ensuring that it's patients who we get them home quicker as opposed to just passing the cost on to other partners. That's not what we're trying to do. Work on that's been very successful. The CHC collaboration, particularly with the support of Neil Carr and his team from the MPF team, working closely with the team at the ICB on that. So that's been definitely a success story for this year. We've seen some of the improvements coming through in the last few months financially. Productivity, some good work done there, I think. I don't know if Simon may want to comment on this, but particularly around some of the theatre productivity around ophthalmology that's been worked on and delivered, and is delivering improvements now to the numbers of cases that we're getting through our lists. Use of the independent sector, again, we're finding quite a significant opportunity around that in terms of really just tightening up the way that we manage that process. And then finally, balance sheet. So work we've done on balance sheet has enabled us to bring some one-off but still important improvement into the position. All that has culminated in a steady improvement now in the second half of the year. So I mentioned the 100+ million that we saw at month 4. At month 7, we were looking at a 64 million miss of the target. We reduced that to 56 in month 8, and now in the reports to 39 in month 9. And working with my CFO colleagues, we think we can now get sub 30 million as a system miss, which, whilst it's still a miss, it's less than 1%, and coincidentally is less than the cost of the binding conciliation. So in a sense, we set out with a view that we were going to deliver in significant levels of efficiency, and we have done that. Unfortunately, a lot of it through non-recurrent means, as I mentioned earlier in the earlier item, but nevertheless we have delivered those improvements, and so we have got quite close, Chair, to the financial target at the end. We think we will by the end of the day, obviously all subject to audits. I'll stop there because this is obviously scrutinised in detail at Finance and Performance Committee. See if there are any questions on the finances, and if not, hand to Hayley. You're on mute, David.
Apologies for that. I had a momentary dip in internet coverage and had to rejoin at that point. Thank you very much, Paul, for that. Just want to check, is there anything anybody wanted to come back on? Simon, anything on the issue that Paul raised? Or Neil,
no,
from
thank you.
MPFT perspective?
No, thank you, David. I mean, as Paul said, the help, the assistance has been very helpful in sort of shining a light on some of our productivity issues, and any external assistance we can have in improving matters is going to be, as ever, very warmly welcomed and received, and only helps us with tackling the waiting lists, but also making sure we get maximum productivity. So it's all very welcome. Clearly we're in the earlier stages of it, really, in terms of impact, but it's a work in progress.
Thanks, Simon. Neil?
Nothing to add, Chairman. I think we've worked very productively with the ICB. Thank you.
Yeah, thanks, Neil. Mish?
Thanks. And just to update on the workforce INI input. So we have reviewed the input that we've had over the last few months, and going forward, what we're doing is refining for each organisation the best activities that are going to get us the most productive outcomes. So focusing on high cost agency, obviously bank reduction, using technology in a different way to be able to fully understand the position and the use of temporary staffing, I think that job planning and rostering is probably going to be the next area of focus. So working really closely with the CPOs and colleagues on that.
Thanks, Mish. Okay, Paul, I think, shall we hand over to Hayley and cover off the performance piece if we can?
Thank you, Chair.
Thanks, Hayley.
So within the pack, there's some very detailed performance information, but would just like to pull out a few highlights if that's okay. So in relation to urgent and emergency care, as board has heard for the last few board meetings, our urgent and emergency care position remains really challenged. As is the national picture, winter arrived early for us, and we saw rapid rise and spikes of pressure early in the season, which unfortunately resulted in 5 provider critical incidents, and we also had 1 system critical incident during November into December. And the rationale behind the reason for the pressures, very much is multifactorial. Our emergency departments have seen higher attendances than expected, and indeed it was a 3.78% increase against the same period last year. So that's January 25 against January 24. And in addition, we've seen emergency admissions that have had a 1.3% month-on-month increase. Bed occupancy has remained high, although not too much above the national standard of 92%. One of the biggest factors for us has been the infection rate, so the IP restrictions of infections such as flu, RSV, COVID and norovirus. We've seen them all concurrently across the months of winter, which brings really difficult challenges to flow and to capacity. And indeed, at the moment, the Midlands position is really very challenged, and they stated it's the worst norovirus situation in 5 years, and 55% more beds have been lost due to norovirus this year so far compared to the same period last year. For our population, we've seen unacceptable delays across our UEC pathways, and notably delays in ambulance response times. However, January was just over 32 minutes. That is an improved position against November and December. December was circa 50 minutes. So we have made some improvements from that perspective. We have a number of ambulance lost hours, so that's ambulances that have had delays in handover, impacted all of our sites, but especially Royal Stoke. So our winter surge, the plan came to November ICB board, and it outlined our actions, which were predominantly capacity and enabling actions to support us getting through winter. What we've done in response to that, I think we said at the time that plan was an iterative process. We would adjust the plan according to what we needed to do, according to the pressures. So we've continued with some extraordinary actions, which has been additional capacity in primary care. We've had additional spot purchase community bed capacity. We've increased staffing in our single point of access, which has resulted in a 20% increase in demand, which has supported us with deflecting patients onto alternative pathways and not going to an emergency department if they didn't need to. We've had a clear focus around our care home support, and our integrated coordination centre has had a key part to play in that. So that said, it's not all just about capacity. We've got a lot of work to do across the system around process. Heather talked about the HIT interventions that we've been doing over the last number of weeks, supporting the acute setting with identification of discharges, not referrals. And our key focus around that is to work across the system in a multidisciplinary team way, but also to embed some of the learning that comes from those twice weekly interventions. I think it's fair to say that the pressures for our workforce have been relentless. We have seen high sickness levels. Of late, they have been reducing, which is really good to see. So in winter in general, we're undertaking a review. We've been doing that, as I said, as an iterative process. We are going to our Finance and Performance Committee monthly with our latest review, and all of this will feed into a full winter learning process in the spring. We're really keen to ensure that everything that we have learned through this winter review process goes through into our planning for future winters. We've worked incredibly well across the system. There's really great collaboration across all partners, and our significant response continues to be undertaken by everyone in response to the pressures that we're witnessing. So that was all for UEC. Just briefly on elective. So our planned care performance, board will note that we've had a long-standing long wait position for patients requiring elective care. Just wanted to point out that whilst winter has had a bit of an impact on that, in that we've had some cancellations of elective care, we have made significant progress. So our 78-week cohort for March is projected to be down to single figures, which is really great to see. And our 65-week wait cohort is under 200 patients. And considering we had this time 12 months ago, we had over 30,000 patients. So I think that the immense achievement that we've seen there is a really great point that I wanted to make. That's all from me. Thank you.
Okay, thanks, Hayley. Simon, I guess you just want to come in on a few points, do you, that Hayley's made?
Yes, thank you, David. If I may, I mean, Hayley's said it all already, but I suppose it would be remiss of me not to chip in, particularly about the UEC position given the last few weeks and months that we've had, really since the tail end of October. Really, but particularly in December and January. So I think, as Hayley's already pointed out, the overall numbers in terms of increases in attendances and admissions, when you're talking less than 5%, appears overall quite modest. But I think what that does tell us, and we shouldn't be surprised, should we, about actually there's so little resilience in the whole system, that even relatively modest numbers like that really do tip us over, and UHM is no outlier in that regard, and I'll talk about the impact that has on it in a moment. Infection with in all of the infections that Hayley's already spoken about have undoubtedly made things worse, particularly more recently, actually, as Hayley said, norovirus, which we're looking at 5 times the level we've seen, and the Midlands has been the worst affected, and that norovirus is a very difficult infection to control, very, very contagious, and in some of our particularly older estate, when you haven't got single bedrooms, it is very difficult to manage, and we see that happening. And again, it doesn't take many beds to be had out the system, and that has an impact on the front door, and that's what we're seeing, regrettably. I suppose the one thing I wanted to say as we go into this sort of lessons learning process, although winter's clearly not over yet, UEC remains our #1 collective system priority, but not least of which at UHM is our #1 priority. I cannot apologise enough to the patients and families affected by the delays and being on the backs of ambulances, etc. It is thoroughly unacceptable. We are doing everything in our power to mitigate the worst impacts of that from a safety point of view, but obviously from a patient experience point of view, and learn the lessons for next year, and taking that very seriously internally. But I refer you back to the conversation we were having earlier on in this meeting about community transformation and what we need to do differently in terms of the interface between all of our providers. And I think we are coming together very well on all of that as we move into the delivery mode. You probably aren't aware that I've appointed an urgent and emergency care recovery director specifically with expertise in this area to help us and give us the leadership bandwidth and expertise in this field to lead a programme of improvement over the next few months to prepare us better for next year. And Hayley is a regular attendant at the 9:30 meeting that we chair 7 days, that I chair 7 days a week, that gives us the overview of where we are. And I would say, I would echo Hayley's comments that we work very well together as a system. And when I put my hand up asking for help from partners, they're always there as requested. So I think that stands us in good stead. That's all I really wanted to say. As I said, I think it would, if I didn't comment on UEC, it would seem incongruent if I didn't.
Yeah.
So
Simon, thank you for that, and also thank you for the honesty and transparency in terms of you know, the current situation. Really good as well to hear the UEC recovery director has been appointed. John.
Thank you. I'm not quite sure whether we're coming out of winter or not. What Simon's just said about neurovirus means that maybe we're not quite there yet. But I just feel that I would like to say this actually on behalf of the whole board, but I hope everybody would agree with this. Just to convey a huge thank you to all of the staff that have worked so unbelievably hard through the winter. There's so many different teams, isn't there, in primary care, in community health, in terms of the emergency department, obviously the ambulance team, the acute medical unit, intensive care, on the wards, and the discharge team. Where would we be without all of them? And indeed the social care staff as well. The reality is, without their extraordinary above and beyond care, we would be in a worse position. It's as simple as that. And I just feel strongly that at this point in the winter, we should just recognise, you know, all of that work. At times, I'm sure some of those teams felt overwhelmed, but they kept going, as they always do. And I think we should just honour them in this board meeting.
Yeah, John, thank you for that. And you've actually stolen my thunder. That's exactly what I was going to move to, but very well put, and will go out in the summary report from the board. Yeah, absolutely fix on that. Hayley, the only point I'd got to raise was just about the learning exercise going forward. As John said, we're not quite out of winter yet, but we'll be in a month or so. How is that going to be different this year to probably previous years? Because in previous years, it's almost like you get through winter, not quite breathe a sigh of relief that it's gone, and then get on with the next issue that we're dealing with. How are you going to pause and actually really get under the skin of that and hopefully get the plan into a stronger position really for the next year?
Yeah, great question. Thank you, David. So I guess this year, the thing that we have done differently is that we've had an iterative review process underway. So we're almost in the review position all of the time. And I do think that the monthly governance process we've wrapped around this has really helped that. It really focuses the mind, doesn't it? We're going to the Finance and Performance Committee monthly to review our findings. Our UEC board plays a huge part in the review process. Obviously, they're there for the governance, but also, you know, for that kind of debate and challenge around some of the factors that we are picking up. We will be having a post-winter wash-up session with all partners, and we will be outlining what all of the learning has been and the changes we need to make, I guess, to our future winter planning arrangements. I feel that we've been much more in the space of learning this year, and it has been, and it still is, an incredibly difficult winter, but I think having some of the external support that we've had, so we've had an NHS England review that's been focused around UHM and some of the system interfaces as well. And obviously we have Caroline in UHM at the moment that is focused around UEC improvement. So I think that the key task in hand for us is to bring together all of that learning and work with all of our partners, so all agencies, including the voluntary sector, in understanding how we can do things differently. I guess alongside that, the community transformation work and things like the review of the Better Care Fund gives us opportunities to do things differently in terms of what our range of service provision might look like and how we invest the money that's currently sitting within UEC.
Thank you, Hayley. Okay, so just pause if there are any final points. If not, Paul, thank you. Hayley, thank you. Megan, just coming to you, Megan. I know we haven't got an AA escalation report. Anything you want to add to anything that's been reported?
Yeah, we have actually, David. There is one attached in the pack.
Oh, sorry, have I missed that?
So
okay.
Yes,
sorry, I've got it.
Okay, there are a few things I wanted to pick up, but they have mostly been discussed throughout the meeting. I wanted to mention the improving level of unmitigated risk, but the significant challenges that we still have to get to a break-even position. But that I think I really want to support the amount of work that's been taking place to get us to that improving level of mitigated risk, because it is a huge effort from across the system to get to where we've got to at this moment in time, and then hopefully improve further before year end. I wanted to mention the tough choices work stream and the fact that it does feel now that is moving forward at pace. And just to assure everyone that there will be a full impact assessment for each scheme before approval. I wanted to mention the work around supporting our care homes, and it's felt like it has taken us a while to get going on this, but it does feel now, and it felt very much at the last committee meeting, that we now have got a real handle on this work going forward, and with clarity around the immediate and medium-term actions that we can do to actually improve support for care homes. Concern around the strategic capital plans I mentioned earlier, and finally, actually, I wanted to mention that the committee reviewed our terms of reference and agreed amendments reflecting the provider selection regime requirements and the new strategic commissioning committee, and those amended terms of reference are appended to this report for ratification by the board this afternoon. Thank you.
Thank you very much, Megan. Okay, any reflections on anything that Megan has raised? If not, we'll move to the recommendations for both reports. Acknowledge the high level performance against the 5 priorities, acknowledge the high level key program deliverables update and the financial position, and to receive Megan's escalations and ratifications. And just to endorse the point that John made and Megan has made about the considerable work that's going on across the system to keep the ship upright during this challenging period. So thanks to everyone involved in that, and Tracy will make sure that goes out in the board briefing report that goes out after the board. Okay, let's move on if we can to People and Culture Inclusion AA report. Showkat, are you still on the call? If Showkat isn't on the call, Mish, I'll ask you if you will take that, because he did note that he may have to drop off.
Hi, David. Yeah, I'm still on the call, David.
Great. Welcome, Showkat. I can hand over to you.
Thank you. Thanks, David. David, just very briefly, there was a number of things we spoke about, but there is a kind of underlying theme based on the agenda itself today. So we spoke about the 2025-26 operating plan and also the medium-term plan, in particular the transformation programme. And some of that has already been covered quite in detail already. But one of the things that we did pick up on was around the behavioural, cultural and leadership implications of the transformation work and activity. And I think we've seen that through some of the reports presented today about the challenges for the workforce, that need for collective resources across the system and how the system works, and different organisations come together across some of those boundaries. And we know there's a real piece of work to be done around behaviour, culture and leadership in order to get us into that place, because some of that transformation activity and doing things differently and doing things in a more collaborative way will require a very different mindset from how the workforce operates, not just within the NHS system, but also across local government as well. So I think it was important just to highlight that, and we'll continue through PCI committee to look at the examples of that and what we can learn about how we can collaborate and do things differently. So that's all I really wanted to say, Chair.
Thank you, Showkat. We'll note that point and just pause any points that anybody wants to raise on Showkat's report. If not, Julie, can we move into item 12, the AAA Chair's report for audit?
Thanks very much, David. I did report on this verbally last time, so I'll take the report as read. I did raise the pertinent issues in the last board.
Thank you, Julie. Any comments on Julie's report? If not, we receive and duly ratify 6 policies which were identified for escalation to us this afternoon, correct? Yeah. Thank you. Just moving then into item 13, the Strategic Commissioning and Transformation Committee. As I said at the start of the meeting, it's great to welcome Mike Lawton to the board, who will be taking this forward on an ongoing basis. I covered the meeting for 2 meetings, and this was the 2nd meeting. I'll take the report as read, and just on page 4 of the report, just want to bring to the board's attention a number of issues that I think need to be taken into account going forward as this committee develops, to make sure that it really achieves its real focus going forward. So in terms of benefit clarity, making sure we can explain how we've assessed benefits and robust benefits realisation processes are the papers brought to the committee. Papers should be clear about the patient family care experience and standards. Impact assessments have to be present when papers come forward, and the importance of being absolutely clear on partner input into papers, and that there is a clear chronological record of how that has occurred. And finally, just making sure that the timeliness of the papers is adhered to coming forward to the committee. And Mike, I'm sure going forward, you will take those disciplines and add them to the work programme of the committee going forward. So I'll just pause there if there's anything on that report anybody wants to raise any clarification on. If not, we'll move into any other business. I've had no items identified to me in advance, so just check if there is anything that's absolutely critical we deal with this afternoon. No? Okay, so we'll move into item 15, questions from the floor relating to anything that's been raised at the meeting today, and I'll now open it up for people to ask a question. Alison, thank you very much for being patient. And can I ask you to ask your question? Welcome.
Hello, yes. My apologies to speak out earlier. I'm Alison Garner. I'm the MP for Stoke-on-Trent South. So very briefly, what I was referring to earlier is I used to work for the NHS AI and Digital Regulation Service. So any work doing on to do with artificial intelligence, particularly governance, I'm happy to sort of help out and speak and meet people with that. But my question relates, and I wanted to raise this today. I do appreciate this an MP's meeting on Monday, but I wanted to raise this today about wheelchair services. We're a number of MPs across the country, in fact, but within this ICB area, have been having casework to do with wheelchair services and not delivering the wheelchairs. Now, one case that I've been dealing with, and I need you to know, hence my raising it now, is that they have decided to go to the press. And there is a journalist interested from ITV. So I just wanted to raise the issue of the struggles that we're having and what your answers are with regards to wheelchair services, but also to flag with you that this is likely to become public.
Yeah, Alison, thank you very much for obviously for attending this afternoon first and foremost, and the offer of support that you've given on the wheelchair issue. We'll pick that up in a moment. We are going to raise that on Monday at the meeting with the MPs that we've got set, and we'll make sure that that comes forward with a full discussion. Can I just ask from the executive team? I'm not sure. I can't see Peter on the call, so whether he's having technical difficulties. Elizabeth, are you able to respond to Alison's question?
Yes, I am, David. So thanks for your question, Alison. I look forward to talking about it more when we meet on Monday. But I guess I wanted to provide you with an assurance that we are absolutely aware of the challenges around the wheelchair services. Some of them, they are largely speaking in the wait times for accessing wheelchairs. Some of that's to do with increases in demand, some of that's to do with issues that we need to work through, and we are working through with our current providers. There are challenges nationally, so some of that's to do with the national picture, some of it's to do with some local issues that we are working through. So we're really, as a commissioning organisation, we are really aware of the challenge and we're working through that. We're doing that through our commissioning, contracting and quality routes. There's also been a role for our overview and scrutiny committee where there's been a kind of review, and there were some recommendations made towards the end of last year. We've been working through those recommendations and we're due to report back to overview and scrutiny on those in May of this year. So hopefully that gives you a sense that we are aware of the challenge. We're taking the challenge and the issues that our population are experiencing really seriously. I'm very happy to provide a bit more of a briefing to you on Monday about some of the specifics of how we're addressing that, if that's okay.
That's fine, thank you.
Thanks, Elizabeth. Alison, once again, thanks for attending and thanks for your interest and questions. Welcome, Ian.
Good afternoon, Chair. Good afternoon, all. I've got 3 questions. One's around continuing healthcare, subdivided. Urgent and emergency care, finance and performance, if that's okay. Can I start with continuing healthcare? Continuing healthcare, I realise you're an outlier with regard to the amount of continuing healthcare that you finance, because after all, the NHS doesn't provide it anymore. But fast track continuing healthcare is a facility that has to be offered. Can I have assurances that fast track continuing healthcare is still being offered, and the whole point of fast track continuing healthcare is the fast track? And this has always been problematic for individuals. I've advised individuals with regard to continuing care in the past. Continuing care doesn't have to be provided just in a nursing home. It can be delivered at home. Can I have assurances that that is still a provision for continuing healthcare?
Thank you, Ian, for the question. Heather, do you want to respond to that?
I will indeed. Thank you, Ian, as always, for your question. And just to give you absolute assurance, yes, fast track is still there, still provided, and has not been negatively impacted by anything that we've talked about through our work on continuing healthcare. And yes, it is still possible to have care in your own home, and where appropriate, that can be provided through a personal health budget. So there are options in terms of what you can do with that. So hopefully that covers off your question.
Thank you very much for that.
Thanks, Heather. Ian, urgent and emergency care, yeah?
Urgent and emergency care. I note paragraph 1.1, 1.2 of Heather's report that you are focusing on the fundamentals of care. This is urgent and emergency care, the review of harm, where patients are waiting lengthy times and waiting areas or areas that are not standard, e.g. corridors. Does that include on the back of an ambulance, which has been stuck outside an ED for hours at a stretch? And furthermore, there have been visits to Royal Stoke University Hospital and County Hospital. Are you visiting Queen's, or is another system visiting Queen's? There are areas like Good Hope, Royal Wolverhampton, etc., where I presume the reviews are taking place. How are those then transmitted back to you? And when we're talking about urgent and emergency care, this has become a year-round situation. This isn't just winter. When you're looking at harm reviews, how are you taking into consideration the Office of National Statistics reports that entered the public domain in January, which analysed waits and emergency care for ED and ED and A&E departments, where the longer you wait, the greater there is a chance of harm, including excess deaths, because they then analysed discharge from a hospital or even an A&E and then analysed excess deaths after 30 days. How is that being taken into consideration?
Okay, Ian, a very, very full and relevant question that you've asked there. We'll try and answer most of that now. It may be that some of that may need to be taken offline and brought back and brought forward to the next meeting, but I'll just check with colleagues. Heather, do you want to respond to some of that and then bring in colleagues as you feel fit?
I will indeed, and apologies, I may have forgotten the first part, so I might have to come back to that. So just in terms of the other providers, Ian, and I think we make reference to that in there, in the report, we are working really, really hard. In an ideal world, what we would do with places like particularly Queen's Hospital Burton, where a large number of our patients still go, me included, I'm an East Staffordshire resident, so I go to Burton if I need treatment. We'd absolutely roll our sleeves up and get in there, but we have to respect the fact that we are not the lead commissioner effectively for Queen's Hospital Burton for University Hospitals of Derby and Burton. Yeah. So what we are doing is working with colleagues in Derby and Derbyshire ICB and in Queen's Hospital Burton in UHDB itself to work out a strategy for how we can replicate some of the best practice that we've done, and or they can provide us with assurance that they're taking things to the same level. And I've had conversations about that very thing this week with the chief nurses in both organisations, who I have to say are keen to cooperate with us, although not necessarily for us to then impose our approach onto them, because of course they'll have their own systems and processes established. But we are working to get that. And when we talk about harm in urgent care, we talk about it across the entire system, and there is an expectation, and I very definitely would expect, that if one of our patients came to harm in one of those out-of-area providers, although, of course, Burton's very much in area, but from a commissioning point of view, it's considered out-of-area, I would expect a phone call from the chief nurse at the respective organisation in the same way that Anne-Marie or Liz or Kenny would ring and let me know if there was a problem with any of our patients within our internal system. So hopefully that's picked up that part. I think in terms of the report you referred to, the ONS report, interestingly, I before the meeting, as you might imagine, I just did a final check in terms of actual harm, probably anticipating a question around actual harm on the back of the report that we referred to. And that, you know, we can't say there's been no harm, but we can say that there's been things like pressure damage and such like. But of course, what we can't talk about is harm that may have happened at either of the other ends of the journey. So what might happen while you're waiting for an ambulance, what might happen while you're waiting to get off, unless we've picked that up. So as part of the work that's been done in response to that fundamentals of care visit, there's a comprehensive review, which I've got a copy of internally, in terms of what we've done and how we've assessed the findings of that ONS report that you referred to and applied that to the work that we're doing on the fundamentals of care visit. So I think the short answer, Ian, and apologies if I've gone on a little bit there, is yes, we are absolutely aware of that report and factoring it into the work that we're doing around harm. It's a real passion of mine, harm review. And certainly Kathy works in our team and works along with the urgent care team and the team at the providers, absolutely focused on making sure we're able to define that and understand it fully.
Thanks, Heather.
As part of that care review, the first part was ambulances outside. You talk about within the ED, but it doesn't mention that people with ambulances outside. You're reviewing that situation.
Ian, I think Simon may have put his hand up on that particular aspect. So okay. Do you mind if I bring Simon in, and hopefully Simon can help you with that question? Simon?
Yes, thank you. Yeah, I absolutely confirm that harm reviews take place for anywhere where care is outside of the normal scope of the normal places of care. So it will include ambulances, backs of ambulances, as well as corridor care, as well as any extra beds that we put on wards, etc. So that's baked into the system. You're absolutely right. the winters all year round. Basically, we get an exacerbation over the winter months, but we haven't really seen the winter reprieve that we used to over a decade ago, probably since 2014, if I recall. That was the last time I really noticed that something really different happened over the summer months, and it's been pretty relentless ever since. You're absolutely right in that effect, and to the recent ONS data is nothing new really in terms of our wider understanding. I mean, most of our understanding about waiting for any form of healthcare, whether it's elective or non-elective, we know the longer you wait, the greater risk of harm. And with regards to the non-elective pathway, that backs up the ONS report, backs up a much earlier paper a few years ago now from the Royal College of Emergency Medicine, which talked about that. That's not, I mean, some of that is extrapolation of data, so you've got to be a bit careful about how it's interpreted. And certainly that's not what we're seeing locally. And indeed, my executive team review looks at very crude data all the time about what goes on in terms of incidents, claims, complaints, etc., with regards to UEC issues, and that's not something that we're seeing on a current basis. But of course, it will take a little bit of time for this to play out in terms of things like mortality, and we're not seeing anything like that currently that's out of kilter. But it's something that we. And this is why, in terms of tackling the underlying issue, that's why that's the most important thing to do, not necessarily debate as to how much harm we're causing. We're doing this for the right reasons, and we can't be causing any harm. So we need to tackle the underlying problem.
Thank you very much for that. Very comprehensive.
Okay, Ian. Yeah, and finance and performance, Ian.
Right, finance and performance. Looking at Megan's report, I see there's been quite a dramatic improvement, and I don't know whether I've got this right or wrong. We're looking at, you've got the 90 million set aside. So you've got, that is your control total, the 90 million deficit. So you've effectively, I believe at the last month it was 56 million, around 50 odd million, yeah? You were declaring end of year. What I get from Megan's report is it looks as though it's going down to 36 million. And then you've got this, that's the amber amount, 36 million. But you've got another 15.8 million of rebasing. So it brings it down to, you know, around about 20 million. Is my interpretation of that correct? And then there's a question I'd like to make about productivity. But do you want that now, Paul?
Yeah, let's deal with that first, Ian, and then we'll take your last question. Yeah, Paul?
Yeah, close, Ian, close. Yeah, so it is improving, as I think I said. We've seen steady improvement in the last 4 months now. The rebasing is a subset number, actually. So the overall system number to kind of hang on to that we're reporting in month 9, which we're looking at today, is a 39 million miss. And you're right, that's against a deficit plan of 90, a 39 million miss. What I said verbally earlier was that we, as CFOs, are expecting to make further improvements to that 39 and to shave some more off that, and we're hoping to get into something in the high 20s. That's where we're aiming to go to now.
Right, with productivity, we seem to be in the land of the law of diminishing returns, don't we? But I noticed you mentioned that some post might have to go. As I understand it, the increase in clinical staff has been mainly focused on the acute sector. That the community and primary care haven't seen massive increases in staff. So how are you factoring this in? Because it isn't one size fits all, is it, when you're talking about productivity?
Okay. I mean, the growth, if that's okay, Ian, the growth is actually in all sectors. You're right. It's not. Yeah, it's not. It is sharpest in acute, as you probably expect, given the pressures on acute services right now. But no, there are improvements across the piece. I can't remember the GP numbers. Paul may know those, whether those were increasing or not. But broadly speaking, clinical numbers are increasing in all parts of the service, including mental health.
Thank you very much. Thank you very much, all.
Yeah, Ian, thank you for your attendance and your continued interest. Thank you. Tracy, can I come to you just for completeness to pick up anything that you think we need to raise before we close from the chat?
Yeah, so finally we've had no other questions come in. from any of the public that are watching. But just to note, because members of the public who watch this back won't be able to see the chat, so it's just that Health Watch Staffordshire have put in the chat about their deep dive that they're doing around discharge, and if anyone's interested to get in touch with Anna.Mather at healthwatchstaffordshire.co.uk. And Simon Fogel from Health Watch Stoke was put in about good to hear about the board's exploration and engagement with the Oliver McGowan training on learning disability and autism, and echoed what John Rouse said. So I think for completeness, so anyone listening can see or hear what was in the chat.
Okay, so thanks, colleagues from both health watches there for their comments. We started the board meeting with the leadership compact. I just want to double check at the end that everybody has had ample opportunity to raise any issue they've wished to raise and had time to raise it, and that we have adhered to the principles in the leadership compact. Okay, thank you, colleagues. We'll bring the meeting to a close. The date and time of our next meeting is the 20th of March at 12:30 till 2:30. That will be held in public, and it will be in the boardroom at the Executive Offices, Springfield, Royal Stoke University Hospital of North Midlands. So I look forward to seeing you all there in person. So thank you, everybody, for your contributions and attendance this afternoon, and to enjoy the rest of your afternoon. Thank you.
Thank you. Bye.
Thank you.
Thanks.